Good evening, everyone, and welcome to this Medicine for Members presentation. My name is David Mines. I'm a governor of the hospital. I'm president of the Kidney Patients Association, and I'm also a kidney patient. I've been a patient here for 23 to 24 years. In fact, the first time I came into this hospital, I think I was wearing short trousers. Actually, it's not so strange because my mother used to buy all our children's clothes, so we should grow into them. and in fact, I've still got that first pair of short trousers. I use it for when I go on holiday. But anyway, that's not why we're here today. I'd like to thank you all for coming here, and I hope that you enjoy this presentation. And I guess I should also thank the Royal Free Kidney Unit, because they've taken great care of me, and I certainly wouldn't be here tonight if it wasn't for the care and attention that the tremendous team upstairs have put in looking after all our patients, but in particular they've certainly looked after me, so thank you to them. So we have a very large renal department with some very talented, professional and caring doctors and specialist nurses. So let me just give you a bit of a feeling, statistics about how many patients we look after in the hospital. We have about 3,500 kidney patients. Of those, there are 850 patients on dialysis, 720 on hemo, and about 130 on the peritoneal dialysis. So those dialysis patients are basically being cared for in any one of the 5 satellite units that we have around London. We also have 1,360 patients with which we would call low clearance CKD. We carry out 120 transplants in a year, and we have over 1,100 transplanted patients under follow-up. So I'm one of those 1,100 fortunate patients. We look after about 200 patients a year with acute kidney failure, and these are seen as inpatients. So to look after these patients with the best possible care, we have a very modern acute kidney unit that was opened last year, which is an addition to the existing renal units. So what is acute kidney care? I'm quoting mainly from what you would find if you looked at Wikipedia. Acute kidney injury, previously known as acute renal failure, encompasses a wide spectrum of injuries to the kidneys, not just kidney failure. It's a rapid loss of kidney function, and its causes are numerous and include low blood volume from any cause, exposure to substance harmful to the kidney, and an obstruction to the urinary tract. It's mostly based on monitoring creatinine levels, with or without urine output. Acute kidney injury is increasingly being seen in primary care in people without acute illness. So the awareness of this condition needs to be raised amongst primary care health professionals. Let me give you some more statistics, and these statistics come from a NICE document that was published in August of last year. Acute kidney injury is seen in between 13 to 18% of all people admitted to hospital, with older adults being particularly affected. Conservative estimates of an acute kidney injury cost the NHS somewhere between 434 and 620 million pounds a year. And that is actually more than the total costs associated with breast cancer, lung or skin cancer combined. So early intervention is very important. The inpatient mortality of acute kidney injury varies considerably, depending on its severity, setting, intensive care or not, and many other patient-related factors. But in the UK, it might be typically between 25 to 30%. And a recent study found that there's almost 120,000 inpatient admissions per year included as a coded episode of acute kidney injury. Epidemiological studies, that's a difficult word to say for most people, suggest that acute kidney injury is under-recorded because it may not be included in coding. So it's estimated that in reality 360,000 people per year are admitted to hospital in England with acute kidney injury. Those are enormous figures. Basically, it's a condition that affects 1 in 6 people who are admitted to hospital. And although it is completely preventable, it can lead to death in 1 in 4 of those. So it's a serious area. So let me come on to your speaker tonight, Professor Alan Salama. He's a professor of nephrology at UCL and the Royal Free. His interests have been in immunological kidney disease and transplantation. He has a laboratory that investigates mechanisms of immune dysfunction in systematic vasculitis and transplantation. This will impress you. He's trained at Guy's, the Hammersmith Hospital, Brigham and Women's Hospital, which is a Harvard medical school, and he studied for his PhD at the Royal Postgraduate Medical School. That's Imperial College. And he's carried out his postdoctoral training at Harvard. So he's part of this very large professional and dedicated renal team. He's also an enthusiastic marathon runner when his knee will allow him, and he's helped raise funds for the KBA, and he ran for us in the British London 10K run 2 years ago. Apart from being a very bright guy, he's also a very caring man, and he's an Arsenal supporter. So, I hope you enjoyed his speech. Let me hand you over to Professor Alan Salama. Thank you.
Thanks very much. Right, I should sit down. It's not going to get any better than that. So thanks very much, David. Thanks very much for having me here. To my shame, I didn't really realise these events were going on every month. Since we're one of the largest units in the hospital, we felt that we should try a bit more engagement with all of you and tell you what we're doing and tell you what's going on. And if I don't do too bad a job, I hope we'll get some other members of the Kidney Centre to come down and do some other presentations in the future. So what I want to do tonight is tell you about some basic information about kidney disease, what the kidneys do and how they work and what we tend to deal with most of the time, and then tell you a little bit about the research and the work that we're doing upstairs in the Kidney Centre, where we're trying to really prevent some of the predictable problems that we think may arise that are causing, as David explained, significant morbidity and mortality to some of our patients. Now, it's a very mixed audience. I can see there are some healthcare professionals, there are some members of the lay public, so if it's too simple, I'm sorry, and if it's too complex, I'm sorry, but it's a difficult one to get right. Last week was World Kidney Day. We've missed it by 7 days, but actually my daughter now tells me that her birthday should be a birth week, so I'm hoping World Kidney Week will catch this and we're just in time. This was an event across the globe really to try and increase awareness about kidney disease, because it's one of the problems that I think gets very, very little recognition compared to cancer and heart disease and a number of other conditions, although it's a significant problem for a large number of people. So what do the kidneys do? First of all, there are 2 of them, and one of my old professors used to say the 2 most important organs in the body are the left and then the right kidney. So there's generally 2 of them, and what they do is they control the disposal of water and waste products as a result of the metabolism that goes on in the body. They're very effective at filtering the blood and reabsorbing significantly important molecules and then getting rid of the ones that we don't need anymore. And as a result, they regulate the acid-alkali base within the body very, very carefully. And the amount of acid that's present is very important for how other organs work, such as the heart, such as the neurons, the brain, and so on. They're also an endocrine organ or a hormone organ. They produce a drug called erythropoietin, which is Lance Armstrong's favourite drug of abuse, because erythropoietin goes to the bone marrow and stimulates production of red blood cells. So it's critical if you want to have healthy blood, to have a healthy working kidney. And finally, they activate vitamin D, which is crucial to how you absorb calcium and phosphate and strengthen your bones and maintain healthy bones and muscles in general. So if they go wrong, predictably, as a result of what you now know they do, you can see what goes wrong. They accumulate, you get an accumulation of metabolic waste products, some of which, and we're not exactly sure which ones, but some of which result in a number of different symptoms, such as generally feeling unwell, loss of appetite, feeling sick or being sick. You also get very high levels of acid in the blood. You get high levels of salt that are normally excreted through the kidneys, and some of these salts can be particularly dangerous to other organs such as the heart, so the levels of potassium can accumulate. And as a result of these imbalances in salt, some of the patients who have kidney failure need to regulate the amount of salt that they take in, otherwise they run into problems. You don't filter the blood as effectively, so fluid accumulates. That causes an increase in the blood pressure with all the problems that that can lead to. The lack of vitamin D causes bone disease. There are some abnormalities in the cholesterol and lipid pathway. And then finally, because you don't make enough erythropoietin, people become anemic and develop all the symptoms of anemia, such as tiredness and fatigability. So, two very important organs, the left and the right kidney, causing a lot of regulation of what normally goes on. Now, there are two inevitables in our lifetime. One is that as you get older, you need to wear reading glasses, and nobody can escape that. The other one is that the kidney function, all of our kidney function, declines as we get older. This is a study from the 1950s, which looked at 70 men, white men, and it was a cross-sectional study, which means that they simply took people of different age and looked at what their kidney function was at the time. They didn't follow people longitudinally for 60 years because they would never have got it published. So they took a number of people at different ages and they measured their kidney function. And what you can see is that there's a gradual decline as we get older in the kidney function. And this is assessed by a measure called the glomerular filtration rate. And very simply, this reflects how much blood is filtered by the kidney, and it's measured in milliliters per minute. And you can see that a healthy 25-year-old would have a glomerular filtration rate of about 120 mils per minute, which means that we filter, if you think over a 24-hour period, we filter over 120 litres of blood, and we make maybe 1.5 litres of urine in a 24-hour period. So the kidney is an incredibly efficient organ at concentrating and refining what finally becomes very concentrated urine that contains a lot of excretory products. So this was in the 1950s. There's been subsequent studies in much larger populations of men and women, because women make up 50% of the population. And you can see here that this was a study carried out in Holland. They excluded people based on a questionnaire. So they asked them if they had diabetes or hypertension, if they had other causes that might cause a problem to their kidney function. And what they worked out is that on average, for both men and women, there is a decline of about 0.4, just under half a milliliter per minute per year in your kidney function. So if we start with a kidney function with a GFR, a glomerular filtration rate of 120, most of us won't live long enough to actually run into trouble with our kidneys. And if I show you this, I'll show you this in a second on a cartoon, we have enough reserve in our kidney function, which means that during our lifetime, this won't be a problem. However, what we can say from these studies is that the decline we see starts when we're about 30 to 40. So looking around the room, most of us are in trouble. We've already started to decline. And on average, looking at the different studies, somewhere between 0.5 and 1 mil per minute per year is what you lose. So if you're an average 85-year-old and you had a normal kidney function to begin with, by the time you get to 85, your GFR will have got down to about 55 or 60. Now, this has created an interesting problem for us because GPs now get reports based on the blood test. They get a report of the estimated GFR, which is calculated from the blood test. And there is an alert which goes up when the GFR is less than 60, because this is considered to be chronic kidney disease. But you can see that if you're a completely fit and healthy 85-year-old, you'll have a GFR that's considered to be a disease, even though it isn't. It's a normal part of us all getting older. So we're now having to deal with a lot of referrals of people who come in, referred from their GPs, saying this person has got chronic kidney disease, please see and advise, whereas in fact they've got completely normal kidney function for their age. And this is something that we're now beginning to appreciate a lot more. So, normally we lose between 0.5 and 1 ml per minute per year, but if you have certain diseases, that rate can be accelerated. And if you have diabetes, which can often affect the kidney in about a third of patients, that rate of decline can be somewhere between 4 and 8 times faster. So you could lose between 1.5 and 6 ml per minute per year. So now if you've developed diabetes at a young age, as a teenager, for example, you might very well run into problems with your kidneys during your lifetime and require some form of renal replacement therapy, either in the form of dialysis or a transplant. If you have polycystic kidney disease, so this is a genetic abnormality of the kidneys where large numbers of cysts form and the kidney gets deranged, the function is impaired, then the estimates are somewhere between 3 and 6 times faster than an average healthy person. So a lot of what we do is dealing with this rate of decline in patients who have known kidney disease and trying to slow it down as much as we can so that this doesn't run into problems for patients needing renal replacement therapy. Obviously, if you have more than one disease, if you have more than one condition that can affect the kidney, the rate of decline can be even faster than that. The other thing to bear in mind is that not everyone starts off with the same number of functioning kidney units. So, this is a cartoon of what's called a nephron. This is a single functioning kidney unit, and it's made up of this tuft of blood vessels called the glomerulus, and then a series of tubules in which the urine is reabsorbed, concentrated, salts are excreted and secreted into it, and then finally the urine comes out, here at the end, goes down towards the bladder and is passed out as concentrated urine. Now, if you ask most medical students, we're taught in medical school that there are 1 million of these functioning units per kidney. And not many people bothered to really look into that, but and this is just a slide of what it looks like. Each one of these little circles is one of those filtering units. And you can imagine that it wouldn't be much of a job to give anyone to go out and actually count all of these, but recently a number of groups have actually looked at what the variation is in the number of filtering units that exist in different kidneys. Now, these are autopsy studies, and they've looked both in a Danish population and in an American and an Australian population. And what's interesting is that the average of 1 million is probably a slight overestimate, but the range is enormous. It goes from somewhere from about 200,000 nephrons per kidney to almost 2 million. Now, you can see that depending on how many nephrons you start with, the rate of decline may or may not be important. So if you have 2 million to start with and you have a slightly faster rate of decline in your kidney function, you still probably won't run into trouble. But if you only start with 200,000 and you have a faster rate of decline, you're going to need some sort of help with your kidney function early on during your lifetime. So let me just show this as a series of cartoons to try and make this clear. This is the glomerular filtration rate, the amount of filtration that the kidney does, measured, as I said, in milliliters per minute. And this is time, and the scale is very long. It's a number of years. So this is over the course of a lifetime. And the dotted line shows roughly when you might start to get symptoms and problems as a result of the kidneys not working. Roughly when the GFR gets down to about 10 to 15, you start to get significant symptoms, and certainly by the time it gets down to 10, most people would want renal replacement therapy of some sort or another. So during a normal, healthy person's lifetime, the rate of decline is such that you never reach this line. We die of other causes well into our old age if all goes well. If you start off with a smaller number of nephrons, you don't have as much kidney reserve, you might start lower down with your GFR. If you have the same rate of decline, you might reach that line during your lifetime and you might need kidney replacement therapy. If you have another sort of illness, the rate of decline might be more rapid, and clearly you'll reach that line during your lifetime. So most of the time in the kidney clinics, what we do is we try and make this line as shallow as possible, intervening where we can, controlling things like blood pressure and diabetic control, blood sugar control, using some new sorts of medicines to try and deal with the underlying problems for certain diseases such as polycystic kidney disease, to try and make this rate of decline as slow as possible so that people don't actually ever reach the need for kidney replacement therapy. So most of the time we're trying to do preventative work. What I'd like to talk to you about really for the most of this talk is what happens in this situation. And this is where you have a very sudden, rapid decline in kidney function, which used to be called, when I trained, acute renal failure, now is called acute kidney injury, but essentially means a very rapid decline in the ability of the kidney to function as it should. So there are a number of different causes for this, and some of these, as David said, are preventable. And I'm just going to give you a few, sort of reiterate a few statistics. There are a large number of people who don't know about their kidney problem because they never have had a blood test to check it. And the estimates vary, but potentially up to 1 million people in the UK might have some degree of kidney impairment that we don't know about. This sudden loss of kidney function, acute kidney injury, is not uncommon in the hospital, and we think, according to some of the reports that were published a few years ago, approximately 43,000 deaths could be prevented if we dealt with this problem more effectively. Some of this is awareness, some of this is recognizing it early, and some of it is really coming up with new strategies to try and prevent it, which is what I'm going to talk to you about shortly. What we do know is that if you recognize the causes and the actual development of acute injury early on, the outcome, and you deal with it, the outcome is generally much better than if you recognize it late. So again, prevention is ideal, recognizing it early is the next best thing, missing it completely is a disaster. Now the kidney has an impact not just on the kidney, so obviously the kidney is very important, and in my world the kidney is the most important, but this just shows you that if you lose kidney function, or as you lose kidney function, it has a significant impact on other organs, and especially your cardiovascular, your heart disease. So this graph shows you the incidence of heart disease as the kidney function gets worse. And the kidney function here is represented in GFR, but now it's represented on the bottom line, and as it approaches me, it's getting worse. So the GFR being a smaller number is significantly worse. And you can see that the incidence of heart disease, the risk of heart disease, goes up significantly, almost 2.5, 3-fold more if you've got significant kidney injury. So the impact of kidney disease isn't just on the kidney, it's on other organs as well. And if you do get to the stage where the kidney is irreversibly damaged, as I said, it requires replacement, and this is conventionally done with dialysis, or if we're lucky with transplantation. And as David gave you some figures already, there's approximately 26,000 patients on dialysis in the UK at the moment, and there are significant numbers waiting for a kidney transplant. So the transplant, unfortunately, is ideal but not so straightforward, and the reason is that this is a graph showing you the number of people who are waiting in the green line and the number of transplants that are actually going on in the red bars. And you can see that the number of transplants that are going on over the last 10 years has remained more or less the same, give or take, 2,300 to 2,900, but the number of people who are waiting for a transplant has gone up significantly. This is in the UK. This is in America, where the difference between the number of transplants taking place and the number of people on the waiting list is an order of 10-fold different. So approximately 80,000 people waiting for a transplant and approximately 8,000 transplants going on. So it's a problem. We don't have enough supply, and so again, prevention of the problem in the first place is much more important than trying to deal with the consequences later on. So by the end of this, you're all going to be able to pass your medical school exams, and we're going to test you on this later on. But very simply, the kidney can go wrong for a number of different reasons. The first reason is that there may be an obstruction to the flow of urine out. And this normally occurs because there's a blockage at the level of the bladder or the prostate, or there's a specific blockage within the ureters, such as a stone. But this accounts for a very small proportion of the overall causes of kidney failure. Much more common, especially in the hospital setting, is a problem where the blood flow into the kidney is compromised because the blood pressure drops, or because there's not enough blood in the system because somebody might be bleeding, or because they've got an infection, or an actual problem within the kidney itself because of some drugs that we've used or some agents that we've used to diagnose the underlying problem that the patients come into hospital with, or sometimes because of an inflammatory or immunological attack on the kidney itself. And between those two main reasons, what we call pre-renal kidney failure and renal kidney failure, that accounts for about 85% of all the causes of kidney failure that we see. And this is what I want to talk to you about, and what I'm going to sort of emphasize some of the work that we've done trying to prevent, diagnose and treat this in a new way. So, reduced blood pressure or blood flow to the kidney, drug-induced problems. A lot of the drugs we use to try and treat certain conditions, and the best example really are antibiotics treated for infection, can themselves be toxic in high concentrations to the kidney. So we have to be very careful about the doses that we use in patients who have kidney disease. And in people we don't recognize who have kidney disease, they can develop kidney injury as a result of some of the drugs that we use. Some of the scans that we do involve injection of contrast, which can itself be toxic to the kidney, and if you have 1 or 2 scans or 3 or 4 scans in quick succession, that can cause damage to the kidney and cause an acute kidney injury. But of course you might need the scan to make the diagnosis of what the underlying problem is, so we can't avoid doing the scan because we might not get the information that we need. So we can try and understand a little bit more about these processes, and we can model this using experimental model systems, and this is some of the work I'm going to describe to you now. So the first big group that I'm going to talk about is one where you might have a reduction in the blood flow because of infection, or low blood pressure because you might have undergone an operation, for example, and the blood flow to the kidney may temporarily have dropped and as a result cause a problem. Or there may be certain drugs, as I've said, antibiotics, contrast agents, which can be toxic to the kidney. Now, in hospitals, just again to reiterate the problem, up to 1/5 of patients who come into hospital will have, during their stay, an episode of acute kidney injury. Now, in most cases it's mild, in some cases it's severe, and as a result of that, the hospital stay is prolonged, and in some cases the incidence of patients dying goes up quite significantly. So this isn't a small problem, this is quite a big problem that we need to tackle. The issue is that often we can anticipate this. We know that there are some high-risk groups who are more likely to develop this. People who have underlying diabetes, people who have underlying heart disease, people who have underlying hypertension are more susceptible to getting some of these problems with contrast agents, with antibiotics and so on. So if it can be anticipated, it gives you the opportunity for intervening. And if you can intervene, you would hope that you could reduce the size of the problem. So this is a little bit of science. This is a cartoon to try and show you what happens if the blood flow to the kidney is reduced just temporarily. So on the left-hand side, you can see a kidney, and there's a large cross here suggesting that the blood flow to the kidney has been completely blocked. As a result of the blood flow being reduced, there's a lack of oxygen that goes to the kidney. When there's a lack of oxygen, the cells start to produce all sorts of reactants in an attempt to prevent themselves dying. When the blood flow is then restored, some of these chemicals that have been produced by the cells that haven't had enough oxygen attract white blood cells, a variety of different white blood cells that are trying to repair the damage that's going on in an organ or a tissue that has not had enough oxygen. And one of the critical blood cells that is involved here is a white blood cell, which is called a macrophage. And this is the sort of the chief repairing white blood cell that occurs, that exists. And it's very important in trying to get rid of debris that has accumulated, trying to get rid of dead cells that have accumulated, and sort of clean the whole system up. It's like a very efficient cleaner. Now, we got interested in these cells because they're very important in repair, and there are a number of different varieties of these sorts of macrophages, and they all express different sorts of proteins on their cell surface. And these are, if you want, a sort of antenna trying to receive different signals from the cells to understand what they're meant to be doing. So they're traveling around, they receive different bits of information saying, we're under attack, we are being damaged, we need some help being repaired. And one of these antennae, if you want, is this particular protein that I've shown here in cartoon form. It looks a little bit like the old Pac-Man game, but this is called the mannose receptor, and it's there to bind sugar molecules that are expressed on bacteria, and that sometimes and other molecules that get expressed by dead and dying cells. So we know that macrophages that try and repair express this particular protein. And so we had the idea that if you didn't have this protein, you wouldn't be able to repair as well, and this would account for more damage that occurred. So we tried to look into this, and I came up with the idea that if you lacked this particular receptor, you would have worse disease, so maybe somehow infusing this receptor one way or another would be particularly good for you. And much to my surprise, and it shows just how wrong you can be, the exact opposite was true. So if you didn't have this receptor, you were completely protected from getting kidney damage, which was not what anyone would have expected. And we tried this in a model of immune-mediated kidney injury, and we tried it in a model of ischemia reperfusion, where we reduced the blood supply to the kidney, and then we allowed the blood supply to re-establish itself again. And normally when you do that, what you see is in the top slide, I don't know if it projects, but you can see lots of areas where there are the tubules within the kidney that are now blocked by this pink material, and this causes a temporary damage to the kidneys. And this is exactly what you would see in a patient who has acute kidney injury, because the blood pressure has dropped, they haven't had enough blood supply to the kidney, and the kidneys become a little bit hypoxic, lacking oxygen for a certain period of time. So this is a healthy, healthy animal that has had the blood supply temporarily blocked, and it gets severe acute kidney injury. And then these two on the right are animals that lack this particular mannose receptor. They either have half the amount of mannose receptor or they have no mannose receptor. And it was quite a shock when we looked at these results, because we realized that in fact the animals were almost completely protected. So if I show you this in a graph form, what you can see is ischemia reperfusion injury in the kidney. In animals that have mannose receptor on the left, this would be most of us, and animals that don't have it at all on the far right. And you can see that the amount of injury, this is a score, the higher the score, the worse the injury. The amount of injury you get is significantly less if you don't have this particular protein expressed on these white blood cells. And there's a number of reasons why that might be the case, and we've looked into this. And we've looked into this in a different sort of model where we've injected a drug that can damage the tubules, which replicates what happens to patients when they get certain antibiotics that damage the tubules, and the results were exactly the same. This is now drug-induced injury in animals that have the mannose receptor, that have half the amount, and that have none of it. And again, if I show you a graph of that, the less mannose receptor you have, the more your kidney is protected from this drug-induced injury. So that's very unusual, but it's very exciting, because it tells you that if you could somehow block this particular receptor, you might have a new sort of treatment for preventing acute kidney injury. Now, typically in medicine, if you find a protein that you want to inhibit, you develop an antibody to it, and this is the basis for lots of the treatments that we now use in diseases such as rheumatoid arthritis, where we have antibodies that block particular cytokines that we know are very important in mediating the inflammation that occurs, for example, in rheumatoid. But you can't make an antibody to the mannose receptor because it's too complex a molecule, and none of the antibodies that we have tried to make sufficiently suppress the action of the molecule. So we were slightly stuck as to what to do. And we got involved with a group in Nottingham in the drug discovery unit, some biochemists, and they've come up with a new way of blocking the mannose receptor, and it's currently, they've applied for a patent for this particular molecule, so I can't tell you what it is, not that it matters that much because I don't think it's that interesting, but suffice to say that they've come up with a molecule that can block the mannose receptor. They've come up with a few molecules that can block the mannose receptor, and they can block it in two areas, the little bit at the top in red and this large area in green. So we thought we would test these molecules to see if they actually could do what not having the mannose receptor does in the animals. Let me just show you a couple of other graphs, and then we'll move away from the sort of these sort of bits of data. This is the uptake of gelatin. We've labeled gelatin with a particular dye, and this is how much gets taken up when you have mannose receptor on the cell. We can measure how much gets taken up using a series of analyzers. This is under normal circumstances over here. If you put onto the cells this particular molecule that we've made, you see that the amount of gelatin that gets taken up is significantly reduced with one of the molecules that we've got. The other two don't seem to have such great effect. But this one of them seems to be particularly effective. And if you look, one injection of this molecule lasts for about 36 hours in terms of inhibiting the amount of gelatin uptake. So this looks quite interesting now. We've got a molecule that we think is, well, I'll tell you about the safety. Is it safe? The answer is yes. If you put it on cells at very high concentrations or very low concentrations, the cells don't die. They seem to be quite happy having this put on them. Does it get into the right places? It might not project particularly well, but this is a section on the left of the kidney. These are the tubules that I showed you earlier on. We've now labeled this molecule with a bright fluorescent green dye, so every little green spot you see is some of the molecule that's been taken up, and you can see that it's getting into the areas that we're interested in, because it's getting into those tubules that are damaged during this injurious process. It also gets into the liver, it gets into the spleen, and it gets into the lung, which is quite interesting because ischemia reperfusion, the lack of oxygen, the lack of blood reaching particular organs, doesn't just limit itself to the kidney. That's the bit we're interested in, but it's true in the heart. That's what happens when you have a heart attack. It's true in the liver when you have an acute liver injury. And so this is particularly interesting for lots of different organs, or potentially interesting for lots of different organs. $64,000 question. Does it make a blind bit of difference? Early days, but one of the particular molecules that we looked at, the one that was the most effective at reducing the uptake of gelatin into the cells, seems to be pretty effective at preventing the tubular injury in this model of ischemia reperfusion. The same model I showed you earlier on. Now what we did is we treated the animals with this particular molecule on the day that we did the ischemia and on the day afterwards. And again, this is an arbitrary score, but 10 is the worst it could be, 0 is the best it can be. And at the dose that we've used, and we've only tried one dose at the moment, we see an almost 50% reduction in the incidence of tubular damage using just 2 injections of this molecule. So there's plenty of fools that stood up here and said we've developed something new that's really exciting and it's come to absolutely nothing. So I'm not saying that this is definitely going to work, but it looks incredibly encouraging. It's very safe as far as we can see. We're now trying much bigger doses over a different time period because you might imagine that in people who are at high risk, who come into hospital for operations, who come in for their bypass, who come in for vascular surgery, diabetic patients who are undergoing CT scans with contrast, people who we know might be exposed to certain drug combinations that might be toxic to the kidney, you might be able to give them 1 or 2 days of this particular inhibitor of the mannose receptor, which would prevent the acute kidney injury or certainly reduce its severity, which would have a positive impact on all the other things we've heard earlier on, length of stay in hospital and possibly mortality. So it's a very exciting area. We've also shown that with all 3 of the molecules that we tested, we see a reduction in the markers of kidney damage in the urine. So it may be that one of them is most effective, but maybe all of them are effective to some extent. And this is just to show you that in the model where we've actually induced ischemia, those pathologists amongst you now will be expert and tell me that there's quite severe kidney damage here. This is the left kidney that's been damaged, that's had the ischemia, and that's the right kidney that has not had the ischemia. So that's the kidney that's unaffected. You can see lots of the green dots getting into the kidney that's had the ischemia and not so many on the other side. So it may be that actually we're selecting the area of damage where this molecule is getting into, which would be even more interesting because it would have some selectivity that we didn't anticipate in the first place. So, encouraging. It's not the done deal by any means, but if this carries on working the way we think it will, then we'd be very keen on we can scale this up fairly easily, and it's the sort of molecule that would be very easy to apply to patients because the toxicity is extremely low. And this would be the sort of thing that we'd want to carry out a trial on in high-risk patients who we know might undergo acute kidney injury. Okay, so that's a very common cause of acute kidney injury due to drugs or ischemia. The other main area that I'm quite interested in is an immunological problem, which is where the white blood cells get into the kidney and cause damage to the kidney. There are a number of diseases that can do this. You will have heard of some of them, I'm sure, things like lupus. The one that I'm particularly interested in is called systemic vasculitis, and that means inflammation of the blood vessels. And that can commonly cause kidney problems in about 70 to 80% of the patients who have the disease. There is some degree of kidney involvement at some stage. It doesn't just affect the kidneys, it affects the lungs, it can affect the skin, it can affect the nerves. It often relapses, and the treatment for it is generalized, very non-specific immune suppression. It's an autoimmune disease, meaning that the immune system has misfired and is now attacking the patient's own organs, and the way to treat it, unfortunately, is to try and suppress all of the immune response to the extent that the organs are no longer damaged. It's associated with an antibody, which is called an anchor, and there's a reason it's called an anti-neutrophil cytoplasm antibody, and it's characteristic in this particular disease. Is this common? The answer is no. It doesn't affect a huge number of people. But when you look at the number of people who have acute kidney injury who we biopsy, this condition is quite common. So this is two series of kidney biopsies and the causes of damage. And highlighted here, somewhere between 20 and 30% of the kidneys that are biopsied for acute kidney injury have got systemic vasculitis as their underlying cause. So it's not common in the world in general, but in terms of what we see in the kidney unit, it's not uncommon. And I'm going to give you just one very quick clinical example of a patient who we had, who was a 40-year-old, who was referred from the ENT surgeons, the ear, nose and throat surgeons, who had these symptoms for a few months: stuffy nose, nosebleeds, bad headaches, joint pains, feeling generally pretty unwell. She had normal kidney function when she was referred, and she did have this antibody in her blood. So we were quite confident that we could make the diagnosis of this condition called systemic vasculitis, this particular form that was called Wegener's granulomatosis. And we treated her with our standard immune suppression. And she did really, really well. She came back to see us on a monthly basis. She bought me biscuits, which is why I kept inviting her back. Wagon wheels, yeah. So she did really, really well over the first year, and as we normally do, we started off with very high levels of immune suppressants to begin with, and we reduced them down over the course of the year. And then I saw her one December. This was about 18 months after the initial diagnosis. I saw her one December. She was absolutely fine, and then she came back after Christmas, and she had the worst time she'd ever had, the worst Christmas in her life. She couldn't get out of bed for a few days. She had joint pains, muscle aches, terrible headaches. And now when we saw her and we did her blood tests, her kidney function had reduced to 30% of what it should have been. And she now had blood and protein in the urine, which is a very telltale sign that there's some sort of inflammation going on in the kidney. So she had a kidney biopsy. This is a section of the kidney. We take a tiny, tiny core of the kidney under local anaesthetic, and those little red circles that you see, they're the glomeruli, they're the functioning filtration units that I showed you earlier on the cartoon of. So we took a few of them out. She's now got 1, 2, 3, 4. She's got about 6 or 7 less than she had before we started. And what it showed, this is a normal glomerulus on the left, and these are hers on the right. She has lots and lots of white blood cells that have got into the kidney that are causing damage and that are preventing the kidney from filtering properly. We changed her drugs around. She thankfully got better, but it raises the question, or a number of questions. Why did she develop kidney disease under our nose? That's not meant to be a pun because she had nose disease, but why did she develop kidney disease while she was on treatment? And is there some way that we could have predicted that she would have developed this? Because if we could have predicted it, we could have changed her treatment. We might not have reduced the treatment to the same extent as we did. We might have somehow flagged that she was going to be somebody who was at high risk of needing more therapy. And it also raises the question, do we have the right treatments at the moment, or do we need to develop new treatments? And these are just a couple of the questions that in the last 10 minutes I want to deal with. So in this particular disease, prior to immune suppression, this is a study from the 1950s, and it really represents what I would call the natural history of the disease. There was no treatment in 1958 for this condition. Steroids hadn't really been used clinically to the extent that we've got them now, and there were no other immune suppressants that were readily available. And if you see, this is what's called a survival graph, so it's pretty grim. And 101 means 100% of the patients are alive, and 0 means none of the patients are alive. And the time scale is on the bottom. And you can see that within the first 12 months of having this diagnosis, somewhere between 85 and 90% of the patients were dead. So this was an awful disease to have prior to the invention of immunosuppression. Now with immunosuppression, it's completely reversed. Within a year, now the graph is shown backwards if you want. This is now the percentage of people dying as opposed to surviving. And you can see that only within the first 12 months, about 11% of the patients have died with this condition. So from 90% to 11%. So that's a big advance over the last few years. But when we looked at the reasons why the patients were dying, about half of the deaths were due to infection. And the infection was related to the treatment we had given them. We're pretty sure about that. The immune suppression, the side effect of the immune suppression is that you can't fight infectious agents as you would do normally. And half the deaths that we saw in the patients were due to infections, and only a small proportion were due to ongoing disease. So 50% we might have overtreated a little bit, 14% potentially undertreated. We don't have a good way of knowing how much treatment to give. And the other thing is, despite treatment with all of these immune suppressants and the risk of dying as a result of that, a significant proportion of people have a relapse. And this is the total number of relapses according to the sort of antibody you have, so it doesn't really matter. But overall, what you can see is that over a long period of time, this is months of follow-up, so this is over 20 to 30 years we've been following patients. You can see that somewhere in certain groups, 70% of patients will have a relapse. In another group, about 50% will have a relapse. So we're exposing people to drugs that can cause problems, and despite that, the disease is still active, or can be active. So can we predict the relapses? That would be a great thing to be able to do, because we could then customize treatment for people who need it the most and take away the treatment or reduce the treatment in the people who are getting side effects and don't necessarily need it. Can we use the antibody that we can measure in the blood? And the quick answer to that is no. So the antibody is present when patients come to the clinic. We see the antibody there to begin with. This is a small survey of patients in the clinic. And what it shows you is that despite being very well, being in what we call disease remission, having no signs of disease activity, half of them, or over half of them, have still got a positive antibody. So the presence of the antibody or the absence of the antibody is of absolutely no use in telling us whether the disease is active or not. So we can't use that. A group in Cambridge have isolated white blood cells from the patients when they first present, and they've looked at different genes that are switched on or switched off. And these pretty pictures are what are called heat maps. And if it's green, it means it's switched off. And if it's red, it's switched on, a little bit like a traffic light. Well, actually, that's the wrong way around. These are heat maps. They show that there are different patterns of gene expression in patients who go on to have a relapse and patients who don't have a relapse. So if you have one particular sort of gene expression, you're much less likely, you have fewer relapses than if you're in this group in red, where the number of relapses is quite high. So this was done in a cohort of about 30 patients, and this is now being tried prospectively to see if we can use this as a treatment, a diagnosis rather, to tell who might relapse and who might not. It's a way of looking at the gene expression. We had an idea to look in a slightly different way. We actually went back to the kidney biopsy and we said, well, what are the cells that are causing the damage in the kidney? Can we tell something about them? And we come back to my favourite cell, which is the macrophage, which is a sort of white blood cell. It's a sort of two-faced cell. Sometimes it causes damage, sometimes it causes repair. And when we looked at the cells that were in the kidney, in the areas that were inflamed, just like that lady, the patient I showed you, there were lots and lots of macrophages, and they expressed one particular protein, which is called calprotectin. So it's very interesting. If you get a kidney biopsy and you stain it, you can see that lots of the cells express calprotectin. But that doesn't really help, because by the time you need to take a kidney biopsy, they've already got the disease and it's a bit late. So we went on to look at whether measuring the level of this protein, this calprotectin in the blood, might be useful at predicting who was going to relapse or not. And we took advantage of the fact that we've been involved with a number of different clinical studies over the last 20 years looking at this particular disease. And we separated people into whether they had gone on to have a relapse or had not had a relapse with this condition. And we measured the level of this particular protein in their blood. And what we found is that the patients who relapsed had significantly higher levels of this protein once they started treatment compared to the patients who didn't relapse. So what this means is that once you start treatment, if we can measure this blood test and find that the level is particularly high, you mark yourself out as somebody who is much more likely to relapse and therefore would be somebody who we wouldn't want to tail the treatment down in as rapidly or as much. If, on the other hand, you drop the level of this particular protein to a low level, you actually mark yourself out as somebody who's going to do quite well, is very unlikely to have a relapse, and so would do quite well if we withdrew the immune suppressants, which would minimize the risk of side effects. So again, small numbers to begin with. We've now got together with a group in the US and a group across Europe. We've got 500 more patients enrolled, and we're now testing this in a group of patients who've had quite significant relapses. And we're testing this idea that the failure to reduce this level of protein in the blood when you start treatment is a very good way to predict who needs more treatment or who needs less. And we received a grant from Kidney Research UK to try and help us do that work. And we're almost done with that. We should be finished in the next month or two, and we should be able to have some results. The alternative to trying to predict who's going to relapse and who isn't is to leave everyone on some treatment. A lot of units do this. We do it as well to some extent. And this is an interesting study. This is, again, a survival plot to relapse. This is the number of patients who are going on to relapse, who are either on no treatment, and that's the solid line. It's difficult to tell, but here's the solid line. Or they're on a small amount of steroid, less than 5 milligrams of prednisolone a day, or they're on more steroid, more than 5 milligrams of prednisolone a day. And the truth is, it doesn't make a blind bit of difference, according to this study. You get the same relapse rate whether you're on no steroid, some steroid, or a lot more steroid. So we may not be actually very good at predicting who's going to relapse, and we're leaving everyone on treatment, and all that happens here is that the people who are on steroids are accumulating side effects from their drugs for no real benefit. So can we think about another way of trying to work out who would benefit and who wouldn't? The immune system is a little bit like a seesaw. For most of us who are well, the balance between inflammation and what I would call regulation or suppression of inflammation, the seesaw is in the middle. It doesn't tilt one way or another. If the immune system goes wrong and it tilts in favour of inflammation, you develop what we call autoimmune disease. And the disease I just described to you, vasculitis, is one such example. So autoimmunity, the balance of the natural regulatory mechanisms compared to the natural inflammatory mechanisms has been tilted the wrong way. But there are some patients who seem to have re-established this seesaw and re-established the balance. And they are patients who did have disease to begin with, but now their antibody that was positive has become negative. The disease that was active is now in remission, and they are no longer taking any immune suppressants whatsoever. There's not very many of them, but they definitely exist. And so again, we had the idea that they might be able to tell us something about what's going on. So, could we look at the patients who have naturally overcome their illness, work out how they did this, and then see if we could apply it to other patients who are still on treatment? So, after losing a lot more hair, applying to the National Institutes of Health in the States about 3.5 years ago, banging on their door for a while, having weekly calls with them, occasionally losing my cool. We managed to get some funding to do a study which would answer exactly that question. Let's look at the patients who've overcome their illness. Let's study what's happened to their immune system, and let's work out if we can find a signature which tells us how you switch off the disease. Because if we can work out what that immune switch is, first of all, we might be able to apply it to other people. And secondly, we can work out if some people have already done it and we're still treating them with drugs, we could stop the drugs. So I didn't come up with a name. I wasn't desperately happy with it. By that stage, I was so desperate to get going with the study that I didn't really care. So it's called Avatars, and it's really, the idea is to look at these patients who've re-established their immunological tolerance. So their seesaw, having been tilted one way in favour of autoimmunity, has now come back to that neutral position. And we're comparing those patients to patients who have multiple relapses and to healthy controls. And what we're doing is we're isolating all the different individual white blood cells, and we're looking at the genes that are switched on and the genes that are switched off, and we're looking at about 100,000 genes in each cell. And we're comparing the patients who've switched their disease off with the ones who have got relapsing disease. And we hope to generate some heat maps like the one I showed you to try and understand what that immune switch is that can effectively terminate the disease. And of course, we were looking for some, and this is what the plot would look like. This is how we isolate the individual white blood cells. These are the numbers here at the bottom represent different sorts of white blood cell. This is the sort of macrophage type cell. These are B cells that make antibodies, and then these are T cells that you will have heard about, CD4 and CD8. And so we can analyze a number of different genes in each of these cells and work out whether they're switched on or switched off.
You will have seen, I think, across the hospital, I know some of you were involved with this, we've looked at healthy controls as volunteers to compare with our patients. And the fact is that systemic vasculitis tends to affect the population of over 65, and that's why we were trying to target the over 65s as healthy controls. And we've got some, these are very preliminary data, and we haven't really looked at very many people, but when we compare the patients who've overcome their disease to the ones who still have signs of disease activity, in that they've still got the antibody, we find there's a big difference in their regulatory cells, the cells that normally switch disease off. So we already are reasonably confident that we might be able to pick up some sort of immune signature that separates these two groups out. So I showed you this before. I said treatment is effective, but there's a cost to it. The cost is that there are a number of infections that arise from it. And then just the last couple of slides. This is a list of side effects from the two classic drugs that we use in this disease. We use steroids and we use a drug called cyclophosphamide. Steroids can cause blood sugar to go up, they can cause cataracts, bone fractures because of osteoporosis, infections. And cyclophosphamide, when it was first introduced in the 1970s, was used in very, very high doses. It was only after about 10 years that people realised the real toxicity of the drug, and this included infertility, bladder cancer, lymphomas, and bone marrow abnormalities. We now use the drugs at much, much lower levels, and these side effects are vanishing in the brain. But some of them still cause us some anxiety, especially if we have to use it in younger patients. The issue of infertility is a big problem. So we used to think that the main drug causing the problem with infections was cyclophosphamide, because it's a very, very effective immune suppressant. And then a number of studies came along and compared a new sort of drug, a monoclonal antibody called rituximab, and compared it to cyclophosphamide. And it was just as good. But the interesting thing was that the side effects were exactly the same. The number of infections, exactly the same. The number of deaths, exactly the same. So all of a sudden we started to think maybe this wasn't cyclophosphamide that was the big problem. Maybe it was one of the other agents that we were using. And when we look back on all the trials that we were involved in, the one thing that was the mainstay throughout all of these, that was introduced in the late 1960s, at a dose that was made up and has never really been challenged, is steroids. Now, steroids are very, very effective drugs, there's no question. They're incredibly useful. They switch off inflammation very, very rapidly, but they have a number of side effects. We don't really know what the best dose of steroids to use is. No one's ever done a study comparing high, low, and medium doses of steroids. No one's really ever done a study in autoimmune disease looking at whether you can get away without using steroids at all. So we asked the question whether there was a way to avoid steroids. And over the last 10 years, probably, in transplantation, kidney transplantation, there's been a vogue to move away from using maintenance steroids. And the reason for that is that the new immune suppressants that we use in transplantation have a very high incidence of inducing diabetes. And when you combine those with steroids, the incidence of diabetes in the new transplant patients went up to almost 40%. When we dropped the steroids, the incidence of diabetes came right down again to 15%. So steroid avoidance protocols in transplantation have become quite common. We're one of the units that uses that. So when you used to walk into the transplant clinic when I first started training, you could always tell the patients who were on steroids because they had all the classic side effects of steroid usage. And now when you walk into the transplant clinic, I would challenge a lot of the patients to know who's transplanted and who isn't, because we don't see those side effects anywhere near to the same extent. We're now involved in a big clinical trial that's being done across the UK, and in fact across Europe and the States, looking at lupus, which classically uses steroids, looking at new patients who are diagnosed with lupus and seeing if we can avoid steroids. And I think one of the tricks we've learned from transplantation is that you need a very good induction therapy, you need a very good treatment to begin with to be able to afford to withdraw on steroids. And a number of years ago I started a study where we looked at combining a very low dose of the cyclophosphamide, which doesn't cause the sorts of side effects that I showed you earlier on, with one of these new monoclonal antibodies. We did use steroids to begin with because we didn't want to change too much. We had a very nice safe profile in terms of the white blood cell, which normally is suppressed if you over-immunosuppress people. And the outcomes in patients who had vasculitis was very, very good. Now we're trying to use this sort of protocol where we use a combination of lower doses of two drugs to see if we can avoid using steroids as maintenance in patients with vasculitis. And we've certainly had some success in people who really wanted to avoid steroids. And this is just to show you one patient who's had a steroid-free protocol, whose kidney function got very bad, that they had disease, and has come back down to normal, and is now avoiding all the steroids. This is something we're trying to look at in a randomised trial to see if this is actually a new way forward, trying to avoid the complications of steroids. Okay, so this is it. I have got a very short video if you want to see it again, which is something we made for Kidney Research UK. There are tissues at the back for those of you who get emotional with these things. It made me cry. So this is just to summarise what I've told you already. Kidney injury is very common, especially in hospitals. A large number of these are preventable. And there are strategies I think we're trying to deal with to see if we can come up with new ways of preventing hospital-acquired acute kidney injury, which would have a big impact on what happens later on. Early diagnosis is really important. We've been educating GPs about this. This is something that everyone needs to be aware of outside of the hospital and also within the hospital. There aren't great treatments for many of the common problems that cause acute kidney injury. What I showed you today is still research. It's very early days, but it's the sort of approach that we and other units are taking, trying to understand if there's a better way of dealing with a very common problem. And if we can develop that, then I think over the next 10 years we should see some big impact on what we're dealing with in the hospital. So thanks very much, and I'll just show you this, just to remind you of World Kidney Day. This is acknowledging everyone who's in the lab, our collaborators. Most importantly, because none of this work gets done without money, these are the people who supported us in terms of funding, local charities, St Peter's Trust, as well as Kidney Research UK and some of the others at Rose Trees. Okay, so if you've got 5 minutes, I'll show you this video.
It's very difficult to see your child okay one day and then laid out on a hospital bed in pain. No parent wants to see their child in pain.
I was away for 6 months. Like, to be able to, I was in the hospital for 6 months. I don't like being in the hospital.
Owen has to cope with a lot of things that most people find unpleasant. He has a lot of blood tests. He has to have a lot of medication. That's all needed pre-transplant.
The second chance that I've had, I've tried to make the best of it. I've tried to do things that I would not have done before. I think I've tried to be a better person. I would be absolutely devastated if this transplant fails.
When I was 19, I went for a kidney transplant. Going through a transplant operation and then having the disease recur would make me very unwell, and it did. We know that you can't stay on dialysis forever, and I've been on it a long time already. 15 years is a significant length of time to be not transplanted. And so I am completely dependent on the research.
Kidney Research UK has been going for over 50 years now, and it's provided a very important stepping stone for many people to carry out their research. But there's still a lot more to understand. There's still a lot more to try and work out how we may have a bigger impact than we're having at the moment.
There's much that we don't know about exactly how kidney disease develops, or the role of kidney disease and its mechanisms. Hence, it is so important that people donate to Kidney Research UK, because that will directly increase the funds that are available to fund vital research into kidney diseases.
The research has to happen, and that's my only chance at actually getting a transplanted kidney, which will hopefully work and then carry me through for the rest of my life.
If kidney research were not funding the research people to do their work, I don't think I would have survived.
The highs are precious. Every second counts. The hard work everybody's putting into researching a cure for kidney disease means that we've got a much better outlook on life, and we can see that Orin will have a really good future ahead.